Assalamu alaikum. Let's dive into carotid artery diseases. First, some anatomy. The common carotid artery. The common carotid artery arises from brachiocephalic trunk. The common carotid artery arises from brachiocephalic trunk on the right side and directly from the aortic arch on the left side. So on the right, the common carotid artery arises from brachiocephalic trunk, and on the left, it directly arises from the aortic arch. It bifurcates at the level of C4 by four kids. That means C4 carotid artery, C4 carotid artery, and bifurcates 4. So it bifurcates at the level of C4 vertebra into internal carotid artery and external carotid artery. Internal carotid artery supplies the brain, including ACA, anterocerebral artery, MCA, middle cerebral artery, and parts of the PCA, posterior cerebral artery. So internal carotid artery supplies the brain, including ACA, MCA, and part of the PCA. An external carotid artery supplies the face, scalp, and neck. Okay, lots of anatomy we have known. Now the management, the very important, the management of carotid atherosclerotic disease. In carotid atherosclerotic disease, intensive medical therapy like aspirin, statin, BP control, aspirin, statin, blood pressure control, plus evaluation of carotid revascularization. First, aspirin, statin, and BP control, then plus evaluation of carotid revascularization. If it is asymptomatic and the degree of stenosis is less than 50%, no benefit with carotid endarterectomy. If degree of stenosis is less than 50%, no benefit with carotid endarterectomy. If degree of stenosis is 50 to 79%, carotid endarterectomy typically not recommended. If it is 80 to 99%, carotid endarterectomy is recommended. So asymptomatic patient, less than 50% degree of stenosis, no benefit from carotid endarterectomy. 50 to 79% carotid endarterectomy typically not recommended. Typically not recommended. In 50 to 79% men, there is a gender ratio. Like for men, there is some sort of benefit, but for female, we actually these 50 to 79% cases, in case of female, we actually like to go for intensive medical therapy only. For 80 to 99%, carotid endarterectomy is recommended, is final. For symptomatic patient, for symptomatic patient age or for symptomatic patient, if degree of stenosis is less than 50%, no benefit from carotid endarterectomy. 50 to 69% carotid endarterectomy in selected patient, carotid endarterectomy in selected patient, like men likely to get benefit from carotid endarterectomy, whereas women likely benefit from intensive medical therapy. And for 70 to 99%, carotid endarterectomy is recommended. Carotid endarterectomy is recommended. Okay, in here I have said something wrong. Like in here, in asymptomatic patient, 50 to 79%, the carotid endarterectomy may be recommended in selective patient with low perioperative risk. If there is low perioperative risk, then we can select those patients. So that is all about management of carotid atherosclerotic disease. Patients with stenosis less than 80% should receive periodic annual carotid duplex surveillance to detect any progression. Very, very, very high yield. Stenosis less than 80%, they should be those patients should be kept on follow-up, periodic annual follow-up, and follow-up by carotid duplex surveillance. Carotid endarterectomy should be considered for symptomatic patient with TIA, stroke, with carotid stenosis 70 to 99% to reduce the risk of the future risks. Patients with disabling neurological deficit, 100% occlusion of the carotid artery or life expectancy. Patient with disabling neurologic deficit, 100% occlusion of the carotid artery and life expectancy less than 5 years are unlikely to have benefit. Okay. Now, carotid artery dissection. In carotid artery dissection, it may be due to trauma, spontaneous occurrence, underlying contributions is hypertension, smoking, connective tissue disease, hypertension, smoking, connective tissue disease. Clinical presentation: unilateral head and neck pain. There may be transient vision loss, unilateral head and neck pain, transient vision loss. There may be ipsilateral partial Horner syndrome, ipsilateral partial Horner syndrome. There may be ptosis and meiosis without anhidrosis. There may be ptosis and meiosis without anhidrosis. There is signs of cerebral ischemia. There are signs of cerebral ischemia, focal weakness. Diagnosis: neurovascular imaging, CT angiography can be done. And thrombolysis if it is less than 4.5 hours after the symptom onset, and antiplatelet therapy, aspirin, with or without anticoagulation. This is all about carotid artery dissection. So trauma, spontaneous and there will be smoking, connective tissue disease, and hypertension, unilateral head and neck pain, vision loss, partial Horner, that is ptosis, anhidrosis, ptosis, enophthalmos, anhidrosis, and meiosis. There is ptosis and meiosis, but there is no anhidrosis. Very, very, very high yield. Ptosis and meiosis without anhidrosis. There may be signs of cerebral ischemia. No neurovascular imaging is CT angiography and thrombolysis. Okay. What is the likely diagnosis in a child that presents with hemiparesis and aphasia after falling down with an object in their mouth? Hemiparesis, aphasia after falling down with an object in their mouth. It may be internal carotid artery dissection. It may be internal carotid artery dissection or thrombus formation. Internal carotid artery dissection or thrombus formation. Traumatic carotid injury. Traumatic carotid injury, penetrating trauma, fall with object penetrating trauma, fall with object in mouth, penetrating trauma, fall with object in mouth, toothbrush, pencil, and there may be neck manipulation, yoga, and sports. Neck manipulation, yoga, and sports. General presentation is general onset, hemiplegia, aphasia, neck pain, and thunderclap headache, CT or MR angiography. This is penetrating or blunt posterior pharyngeal trauma. These toothbrush go and hit the internal carotid artery, and there is tearing of the tunica intima, results in carotid artery dissection. What is the next best step in a young man who runs a marathon and complains of neck pain, runs a marathon, complains of neck pain, headache, right-sided weakness, and vision loss? Neck pain, headache, right-sided weakness, and vision loss. She recently completed a marathon. CT scan is normal, but duplex ultrasound shows absence of flow of the internal carotid artery. Duplex ultrasound show absence of flow in the internal carotid artery. ICA supplies the face and neck. Heparin and oral anticoagulation for 3 to 6 months. Also can do antiplatelet agents for a year. Treatment should be initiated after intracerebral hemorrhage has been ruled out. So this is all about carotid artery disease. That means carotid atherosclerotic disease, carotid artery dissection, and traumatic carotid injury. Hope you enjoyed.